explanation. We must understand first that what is a cartilage. We all know that articular cartilage is a highly specialized, uniquely designed biomaterial forming smooth gliding surface for diarthroidal joints. It has peculiar characteristics like it is avascular, it is aneural, alymphatic, and it is immunologically naive and privileged. So cells are viable elements that are responsible for the maintenance of extracellular matrix of this cartilage. The cartilage has important functions for the joint, like it is a shock absorbing structure, it is elastic, it avoids friction between the bones, and it also protects the bones. So what happens if a cartilage is damaged? We know that cartilage, if once damaged, has a limited capacity for self-repair, and eventually it leads to degeneration of the cartilage and early onset of osteoarthritis. And hence it is very relevant to protect cartilage injuries, and if that happens, we must identify these injuries early and treat them effectively so that we can postpone the osteoarthritis and the need for total joint replacement. We know that cartilage defects affect all age groups, especially the young people after trauma and in old people due to degenerative arthritis. Approximately 50% of the people nowadays have symptoms below the age of 50. So younger people are now getting affected more and more commonly. The factors which contribute to cartilage defects could be mechanical or endogenous. The mechanical causes are overuse and trauma, like in sports people, obesity, joint structure, loss of muscle strength, while the endogenous factors are hereditary disorders, developmental disorders, several diseases of the joint which can damage the cartilage, like inflammatory arthritis, etc. And the nutrition. It has been now seen that vitamin D and micronutrients are very important for the survival and the nutrition of the articular cartilage. There are several risk factors that are responsible for articular cartilage defects, like younger age, female, obesity, previous knee injury, lower extremity malalignment, repetitive knee bending, activities like cross-leg sitting, sitting on Indian type of toilets, high impact activities, and muscle weakness, especially that of quadriceps and hamstring muscles. It is not difficult to diagnose articular cartilage injury, provided you are aware about this entity and you have a high index of suspicion. Usually, as the first line of investigation, X-rays are done in standing position, lateral and axial views. But in the initial stage of articular cartilage damage, these may be normal. Hip, knee, ankle weight-bearing X-rays are required if you are considering or if you suspect a malalignment of the limb. But both articular cartilage defects are best picked up by MRI scans with special sequencing in T2 mapping that can show articular cartilage quite well. And nowadays it is possible to have the biological activity of the cartilage by special sequencing scan like the generic scan. So let's see what happens if a person has a knee pain. Most of the people think, especially most of the patients, that if you have a knee pain and if you go to a doctor, surgery is the eventual answer. Hence, many of these patients do not actually come and see the specialist when it is the best time to protect their joints. You will see this chart that about 2% of these patients who have knee pain require surgical intervention, but most of them can be treated and managed non-operatively by various means, which I will discuss in further slides. So cartilage is a marvelous, tough and elastic structure which is also quite durable. In most patients, it lasts quite well for 60-70 years. John Hunter in 1743 in from London says, from Hippocrates to present age, it is universally allowed that ulcerated cartilage is a troublesome thing, and once destroyed, it is not repaired. So it was known almost 3 centuries ago that cartilage injuries are serious and they do not heal. But we lived in the era for almost 2 centuries where no treatment was done or offered for cartilage injuries, believing Hunter's statement that once destroyed, it is not repaired. But in last about 3 to 4 decades, it has been realized and several attempts have been made to protect and to regenerate the cartilage so that we can postpone the ultimate eventual osteoarthritis of that joint. So the management of cartilage injuries, we have functional treatment goals like to educate patients about the disease and management, to control their pain, to improve function, to increase the muscle strength, and alter the disease process and its consequences, that is to prevent eventual early osteoarthritis of the joint. And this can be achieved by several means like medical, surgical, or nowadays regenerative means, which we will discuss. The non-surgical treatment includes activity modification, weight loss, bracing of that joint using special orthotics, use of pharmaceutical drugs like paracetamol, non-steroidal anti-inflammatory drugs. Nowadays, nutraceuticals have shown a lot of promise in the treatment of early cartilage damage like glucosamine, collagen peptide, rosehip extract, curcumin. In patients with inflamed joint, intra-articular steroids do help these patients significantly and prevent pain. Viscosupplementation and use of platelet-rich plasma is also quite effective in the treatment of pain in osteoarthritis. We still do not know whether they affect the overall natural history of osteoarthritis in these patients. Surgical treatment could be cartilage restoration procedures like microfracture, mosaicplasty, cartilage transplantation, and allografts. Arthroscopy remains the treatment of choice in patients with localized articular cartilage defect, but in patients with angular deformity, especially in younger age, high tibial osteotomy or a distal femoral osteotomy is used. Arthroplasty is reserved for end-stage arthritis that could be unicompartmental or total knee arthroplasty. The treatment objectives for the cartilage lesions are pain relief, reduce inflammation, restore function, reduce disability, and most importantly, postpone or alleviate the need for prosthetic replacement early age. There are several lifestyle modifications that can help these patients, like sitting cross-legged, avoid sitting cross-legged on ground, avoid squatting, avoid sits-up, climbing stairs, using Indian type of toilets, high heels, shoe modification, crutches, braces, etc. There are other things which a person can do to help these cartilage lesions, like simple things like walking instead of running, using alternative exercise program, walking within the limit of pain, walk on soft ground rather than hard ground. Overweight patients should lose weight, and so on and so forth. Quadricep exercise strengthening are also quite important for these patients. Role of orthosis have been revisited recently, and it has been found that cartilage lesion and early osteoarthritis can be managed quite effectively with the use of unloader knee braces, using insoles in the shoe to offload the diseased compartment of the knee. And if you combine these two together, the footwears and the knee orthosis, the effect is even better, as it has been proved in this recently published article that combined use of lateral wedges and knee braces can reduce mediolateral knee joint loading and hence relieve pain and postpone the need for surgical intervention. Some time ago, we published this paper on the non-operative management of osteoarthritis of the knee and concluded that cartilage lesions do not always require surgical treatment. The treatment should be focused on reducing pain, improve joint mobility, limit functional impairment, and preserve a natural biologic joint. It can be achieved by both pharmacological and non-pharmacological means. Non-operative treatment is quite useful in patients with early stages of cartilage lesions. However, in advanced cases, surgical treatment is needed as a definitive treatment. The surgical treatment that can be offered for articular cartilage defects could be divided into three main groups: palliative, reparative, and restorative techniques. Palliative treatment includes debridement and lavage and use of radiofrequency ablation. Reparative treatment like marrow stimulating techniques of drilling, abrasion, arthroplasty, and microfracture are quite commonly used by most arthroscopic surgeons. Restorative techniques are quite promising for larger lesions like autologous chondrocyte implantation, osteochondral grafting using autogenous osteochondral flux by mosaicplasty or fresh allografts. Palliative treatment at best can help low demand patients who have mechanical symptoms or may have present with recurrent effusion. In marrow stimulating techniques, the aim is to expose the chondral defect to the pluripotent stem cells from the subchondral plate to form fibrocartilage. Again, it is indicated for smaller lesion in patients who are low demand. Whereas restorative treatment aims at re-establishing the normal congruity with mechanically stable eyelid cartilage. It is best reserved for high demand patients with significant symptoms and failed prior palliative procedures. But these are complex and expensive, and there is a long learning curve attached to it. Fortunately, cartilage is an ideal tissue for transplantation because it is avascular, aneural, it is immunoprivileged, so there is no problem of immunity. It is amenable to storage and it can be fashioned to any shape and size to fit the recipient defect. Mats Bridberg and Lars Peterson from Sweden were the first surgeons to have invented autologous chondrocyte implantation in the University of Gothenburg, and since then more than 40 to 50,000 patients across the world have undergone treatment with ACI in last 20 years, and the results have now in medium and long term with after successful autologous chondrocyte implantation, because pain and increase the patient's physical activity and postpone the need for any arthroplasty or early onset of osteoarthritis. ACI is indicated for the following indications: chondritis dissecans, focal osteochondral defects of significant size, traumatic cartilage defects, young or early arthritic patient with very localized defects of cartilage, chondromalacia patelli, sports injuries arising out of contact sports, and for articular cartilage defect due to any reason which are quite large, like 20 centimeters square. In autologous chondrocyte implantation, we use the cells, that is chondrocytes, to repair the cartilage. This involves harvesting a biopsy of the patient cartilage, then isolating and expanding the cell in the lab, and then reimplanting them into the patient's defect by a second procedure. ACI has seen a lot of changes in last 2 decades. From first generation, we have moved to 4th generation, where we use gel cell based implant instead of periosteal membrane, which was used in first generation. ACI is a 2-step procedure. In step 1, the tissue is harvested by a biopsy arthroscopic procedure, and step 2 is reimplantation of the cultured cell into the defects. So briefly about the step 1, you have to take articular biopsy, osteochondral biopsy by using special trocar, which comes in 6 and 7 mm diameter. Usually the biopsy is taken from the non-weight bearing area of the patient's knee, from the periphery of the condyles, or from the intercondylar notch. And you can see that there is this cartilage with attached subchondral bone and the bone further down. So it's like a cigarette peg with that you get, and then you send it in a special culture bottle to the lab for cell culture. So these are the diagrammatic representation of the steps that to be followed while taking the biopsy. Once you get the cell culture, then you reimplant, and this is a 2 years post-op follow-up of a patient with a large osteochondral defect on the medial femoral, on the lateral femoral condyle that was treated by ACI. This was the picture before the ACI. You see how severe and full thickness cartilage defect that is present on the weight-bearing area of lateral femoral condyle that was treated by ACI. And 1 year post-op, there is good cartilage cover with complete fill of that, uniform fill of that defect. So the ACI is indicated in high demand patients with symptomatic grade 3 or grade 4 lesions, which are large in size, that is 2 to 10 centimeters square. It is also indicated in patients with prior failed palliative or reparative treatment. Professor Bentley is a known figure in the field of articular cartilage and has done a lot of research and publication on, and he has summed up the present status of cartilage joint repair, that higher is the age of the patient, higher are the failure rates after cellular joint repair. 5 times failure rates if patient has previous history of any surgical procedure in that joint. The results tend to deteriorate over 10 years, and ACI, therefore he recommends that ACI is significantly better as first-line treatment if you have a large cartilage lesion, rather than to do a simple procedure like microfracture in a large lesion and wait for it to fail and then do ACI. So the advantages of ACI includes It's a you put highly differentiated cultured cells into the defect so that you get good quality hyaline cartilage-like structure which lasts for a very long time. It's a proven technique now. Medium and long-term results are good and are available over 20 years. The disadvantages of ACI includes being a two-stage procedure. 2 surgeries have to be done at the interval of 1 month, and cell culture is still quite expensive and not universally available to us. It has been seen now that whichever cellular therapy you use, you may augment its potency and efficacy if you use biomaterials with it. And instead of periosteum cover, you use biomaterials of different types, which acts as scaffold for cell transplantation, and pre-cultured cells, cell augmented matrix for it were also available some time ago. The biomaterials commonly in use are collagen sponge, collagen gel, hyaluronan matrix, PGA and PLA, and most of the surgeons have now preferred to use biomaterial with cellular therapy. So the ACI resurfaces focal condyle defects like hyaline like cartilage, which is biomechanically superior to fibrocartilage. There are several newer techniques that have come up recently in the field of articular cartilage repair. These are autologous collagen-induced chondrogenesis and bone marrow aspirate concentrate. In arthroscopic ACIC, which was developed by Shetty and Kim, these are arthroscopically using carbon dioxide insufflation instead of normal saline infusion. Arthroscopic microdrilling is done of the lesion. Then etylocollagen of fibrin gel application is done as insufflation. The etylocollagen is mixed with fibrinogen and thrombin in a two-way syringe, and then you can use that combined product into the defect and fill. The good thing about this procedure, it's a single-stage procedure where you do not, you can do it arthroscopically without opening up the joint. And these are the steps. You can see you first debride the lesion, then you do microdrilling, then you dehydrate the lesion to make it absolutely dry, and then you inject the cells with the thrombin and into the defect. The bone marrow superclot, that a lot of mesenchymal cells that help in the formation of articular cartilage-like structure. The biomaterials used in ACI are quite good. Instead of taking the periosteum, which was used in some time ago when ACI was started, these act as scaffold for cell. So, friends, the treatment of articular cartilage, and if you are planning to do surgery, should be a combination of cultured cells and a scaffold like collagen or hyaluronic acid, and that actually increases the efficacy and the success rate of your procedure. In future, newer things like meniscal cell culture, meniscal PCL scaffold, we can also use 3D bioprinting of the articular cartilage, implantable distraction devices for early osteoarthritis, chondro, progenitors for osteoarthritis, bone marrow aspirate concentrate for osteoarthritis by way of injection, and cartilage silk scaffolds are also being tried. So there are lots of things that have come up to treat articular cartilage lesion, which was until now was supposed to be an untreatable pathology even by arthroscopic surgeon, and usually a willful neglect was the treatment which most people used to do because there was not much to be done. So the treatment algorithm for the articular cartilage lesion depends on the severity of the lesion and the size of the defect. If you have grade 1 out of reach or ICRS type, then no therapy is 8 centimeters square, then abrasion and debridement or radiofrequency ablation of the lesion microfracture. In grade 3 or grade 4 lesion of larger size, usually BMAC or ACI are the treatment of choice. If you have the facility for allograft, then those can also be done in larger lesions. So to sum up, the take-home messages from this webinar are that awareness about the articular cartilage lesions and high index of suspicion is important in reaching an early diagnosis. MRI is the imaging modality of choice. Only the symptomatic patients with significant cartilage lesions require interventional treatment. Focal cartilage defects are the most preferred lesions for cartilage restoration treatment. These could be marrow stimulating technique, cartilage transplantation, and scaffolds and tissue engineering techniques are now being considered promising for treatment of cartilage lesion. Stage procedures like BMAC, ACIC are becoming popular over two-stage procedure because only one procedure is required, and secondly, it is much more less expensive than two-stage ACI procedure. But whatever procedure you plan to do, any malalignment if present must be treated along with cartilage repair technique, otherwise your procedure is likely to fail very soon. Cartilage repair techniques are for stage 3 osteoarthritis, where alternative treatment like osteotomy or arthroplasty. Thank you very much for your listening. If you have any questions, please feel free to. So the first question is by Dr. Maduka. What are the treatment options in the management of articular cartilage defects? I have already mentioned that these defects, if they are small and in low demand patients, can be treated by conservative means, by pharmacological or non-pharmacological means. But if they are symptomatic and bigger lesions, then various type of surgical procedures that I have just described can be used in these patients. Dr. G.N. Gaikwad from Thane. Oh, video not coming. Dr. Chettiar from Chennai. Following marrow stimulating techniques, defect might use bone formation instead of articular cartilage. Your comments, please. Yes, that's a very good question. In the earlier ACI, this used to be a problem when periosteum was used. Periosteum sometimes used to help in producing bone instead of articular cartilage, but with the use of gel-based techniques and other scaffold display. Dr. Nilesh, this was growth factors and media for cultured cells. Dr. Nilesh, your questions actually is not relevant in the present webinar because this can be answered by people who actually do culturing of the cells. What is the cost of ACI by Dr. Umesh Sakpal? ACI is still quite expensive, mainly because it requires two-stage surgery and the cell culture costs around 1 to 1.5 lakh rupees for each patient. So two-stage surgery plus the cost of cell culture makes it probably as expensive as joint replacement surgery. Your views on growth factor injection for cartilage repair. I've already answered this in Dr. Nilesh's answer. What are the absolute indications? I've already, in my presentation, given the absolute indication for ACI, and these include high activity people with large lesions which are not amenable to other procedures, or if there is previous history of a failed palliative or reparative procedure. Dr. Sheetal, what age patient should be considered eligible for stem cell therapy? We normally recommend this cellular therapy in patients with focal defects in younger patients. So there is no age limit, but if biological age of the joint is quite good, if there is no evidence of any florid arthritis, you can consider these patients for cellular therapy. Does PRP have advantage over intra-articular steroid? Surely it does. Platelet-rich plasma has good concentration of platelets which have growth factors in it, and it has been seen in several studies that the effect of pain relief lasts much longer in patients who had pre-articular steroids. Steroids are only quite good if you have an inflammatory component in the joint with a lot of effusion. In early osteoarthritis, really causes growth of cartilage. See, I mentioned before that procedure which is very commonly used, but it has been now realized that it is not a very good procedure for large. Some people have also seen that it is not a good procedure for early osteoarthritis because these patients tend to get more pain after this procedure and they have to be off weight bearing for 6 to 8 weeks. Moreover, the fibrocartilage that is produced by these microfractures 5 years of the procedure, and hence microfractures are only reserved in low impact for smaller lesions, not for big lesions. Dr. Madhuka again, how would this patient be rehabilitated? Yes, good question, because rehabilitation after any reconstructive procedure of cartilage repair must be done very thoroughly, and the main important key point, keep these patients non-weight bearing for about 6 to 8 weeks, but during this time the patients can be mobile and must do range of motion exercises very frequently, because it has been seen that these exercises tend to strengthen the cartilage repair and molds it quite well to the shape of the condyles of the femur. Is cartilage repair any beneficial in old patients with osteoarthritis? There is no conclusive evidence that all the cartilage repair should be done in older patients with osteoarthritis, and it is not an approved therapy by US FDA as well. Lalit Maniho, what is the status of bioprinting in cartilage defect? Again, an excellent question. I think it is the future in the articular cartilage defect, and a lot of people, especially in Europe, are doing this bioprinting of the articular cartilage for articular cartilage repair, and only time will show, but I am very confident this technique will help the surgeons to repair articular cartilage. Any role of cartilage repair in established ortho where patient not willing for replacement? Well, this is a question which only the treating surgeon should be able to answer, because ethically one should not do any procedure which is not likely to help only because the patient wants that procedure and is not willing to go for the right procedure. So you must still counsel or send the patient to someone else. Thank you once again, everyone, for your active participation. I hope you enjoyed and learned about the articular cartilage through this webinar. Thank you.